Thank you. Thank you for joining us at the California Dialogue on Cancer Surveillance Data Webinar Series. My name is Sheila Senyo. I go by she, her pronouns, Strategic Alignment Specialist for the Comp Cancer Program and the California Cancer Registry. Please feel free to introduce yourselves on the chat with your name, pronouns, and organization, and where you are joining from. So I'll go over some housekeeping while everyone is typing in your intros. I also want to acknowledge my colleague Joy Seha, our Coalition Coordinator Specialist, who's playing a key role in today's webinar production. So all participants have been muted, but we will leave the chat or the Q&A box open for questions. We'll also have an allotted Q&A after the speaker's presentation. Please stay until the end of the presentation to participate in a short webinar evaluation. Again, for those who are just joining us, please type in the chat your name, pronouns, organization, and where you're joining from. The California Comprehensive Cancer Control Program is a CDC-funded program that provides leadership and coordination of statewide comprehensive cancer control efforts. The Comp Cancer Program leads the Cancer Control Coalition, which is CDOC, and is also required to develop and implement a state cancer plan. There have been 5 iterations of the state cancer plan, including the 2026-2035 iteration, which is California's first 10-year state cancer plan. The plan focuses on health equity and prevention to eliminate disparities and improve outcomes. It is currently in the CDPH approval process, and then the plan will be available exclusively online. As a background in areas for the upcoming 10-year plan, CDOC works closely with the California Cancer Registry and other partners to implement strategies from. So our goal is to enhance cancer surveillance system so we can produce and share data in ways that are meaningful and accessible to the public, health organizations, researchers, and other partners. The Comp Cancer Program partners with the UC Davis CalCARES program on our various surveillance goals. CalCARES is an acronym for the California Cancer Reporting and Epidemiologic Surveillance Program. They have supported key strategies such as ensuring wider dissemination of cancer data by producing culturally and linguistically appropriate cancer reports. In today's surveillance data webinar, a UCD researcher will present one of their published reports. Today's presenter, Julianne Cooley, is a senior statistician within the CalCARES program within the UC Davis Health Comprehensive Cancer Center. She leads the production and evaluation of statewide analytic cancer data files for cancer surveillance and research, investigates and identifies solutions for data quality concerns from data users, develops and conducts epidemiologic studies, cancer registry data, and large linked analytic files, and develop surveillance reports that describe the burden of cancer in California. Please welcome Julianne.
Thank you so much for that introduction and for inviting me to speak at the webinar today. I will share my screen and please let me know if I cut out or you're having any trouble hearing me.
I see your screen.
Okay, great. Thank you. So as Sheila said, my name is Julianne Cooley and I'm a statistician at the California Cancer Registry, or CCR. I will be presenting on one of our recent reports, which was on the incidence and survival of early onset cancers in California from 2006 through 2021. First, I'll go over the background of early onset cancers in California, the purpose of our report, the methods that we used, the overall burden of early onset cancers in California, site-specific results for the top 5 incident cancers that were diagnosed among young adults in California, which included breast, thyroid, colorectal, testicular, and uterine cancers. And then I'll discuss survivorship, early onset cancer preventions, limitations of our study, and conclusions. While overall cancer incidence in the United States has remained stable during the past decade, a disturbing trend has emerged among young adults. In incidence of early onset cancers among young adults has increased since the 1990s, with disparities observed by age, race, ethnicity, and sex. Prior studies have observed an increasing trend in breast, gastrointestinal, testicular, and female genital cancers. Increasing incidence of early onset cancers may be associated with increasing obesity, alcohol intake, antibiotic use, environmental exposures, and physical inactivity. Young adults are a heterogeneous group, and they're faced with a unique set of challenges. Compared to older adults, young adults historically have the lowest rate of health insurance coverage, despite increases following the implementation and the expansion of the Affordable Care Act. Prior research has identified racial and ethnic minorities, the lowest income earning young adults, as the least likely to have health insurance. However, even among patients with health insurance, the financial burden of copays, premiums, and costs not covered by insurance may lead to delayed or foregone cancer treatment. Higher rates of late stage at cancer diagnosis have been reported among young adults compared to older adults because they're less likely to regularly visit a primary care provider in the absence of troubling symptoms. The recommended cancer screenings for young adults include cervical, breast, and colorectal cancers beginning at ages 21, 40, and 45 years, respectively. However, screening rates tend to be lower among young adults under age 50 years compared to older adults. One notable study found that the uptake of colorectal cancer screening was less than 20% among adults ages 45 to 49 years. The goal of our report was to quantify the burden of early onset cancer in California and identify disparities in both incidence and survival. We used California Cancer Registry or CCR data to identify cases of invasive tumors diagnosed among California residents ages 20 to 49 years of age at diagnosis from 2006 to 2021, which was the 15 years of most recent complete data that we had at the time. And then among the 5 most common cancer sites, we used NCI, CIRSTAT, and JoinPoint software to calculate age-adjusted incidence rates, or AAIR, annual percent change in incidence rates, APC, and average annual percent change, or AAPC, from 2006 to 2021, as well as the 5-year relative survival. Rates and trends were suppressed when annual counts were less than 20. So this figure summarizes the age-adjusted incidence rates for the 15 most common early onset cancers in California during 2017 to 2021, which was the 5 years of most recent data. And then the first column shows overall for the entire age group, 20 to 49-year-olds. That's the age at diagnosis. And then the following columns are broken up by age groups, 20 to 29, 30 to 39, and 40 to 49. Overall, female breast cancer has the highest incidence at 73.8 per 100,000, which far exceeded the other sites. Thyroid cancer is the second most common at 14.6, followed by testicular, uterine, and colorectal cancer. Incidence did differ meaningfully by age. Among ages 20 to 29, testicular cancer was the most common at 15 per 100,000. In ages 30 to 39 and 40 to 49, female breast cancer was the most common at 46.6 and 158.5 per 100,000 respectively. However, by age 40 to 49, colorectal and uterine cancers did become much more prominent. During 2006 to 2021, there were 171,493 early onset cancers diagnosed in California. Female breast cancer accounted for about 50% of cases, 83,436, followed by thyroid cancer, colorectal cancer, testicular cancer, and uterine cancer. 4 out of 5 early onset cancers were diagnosed among females. driven primarily by female breast cancer and also the predominance of thyroid cancer among females. Most diagnoses occurred in the oldest early onset age group of 40 to 49, which accounted for 64% of cases, compared to 26% of cases diagnosed among those ages 30 to 39 and 10% among individuals 20 to 29 years of age. The stage distribution overall was 51% of tumors diagnosed at stage 1, 21% at stage 2, 14% at stage 3, 7% at stage 4, and 6% unknown. This figure displays the trend in age-adjusted incidence rates, or AAIR, for the 5 most common early onset cancers in California during the study period of 2006 to 2021. All 5 sites increased over the time period. Uterine rose fastest at 3% per year on average. Testicular also increased by 1.3% per year and breast by 0.7% per year. Thyroid increased during the early time period of 2006 to 2012 by 5.9% per year and then was stable through 2021. Although colorectal cancer did increase by 2% per year overall, the segment-specific increases of the APC didn't reach statistical significance. In 2021, incidence was highest in breast cancer at 76.3 per 100,000, followed by thyroid cancer at 14.2, uterine at 12.7, testicular at 12.4, and uterine also at 12.4, and colorectal at 12.1. Now we'll begin examining the site-specific results, beginning with female breast cancer. The overall incidence increased by 0.7% per year with disparities by age and race ethnicity. The highest incidence was among ages 40 to 49 years, Asian and Pacific Islanders, or API, and those diagnosed at stage 1. Risk factors for breast cancer include inherited susceptibility, breast density, delayed reproduction, obesity, sedentary lifestyle, alcohol consumption, and type 2 diabetes for young adults. By age, among 20 to 29-year-olds, incidence increased by 1.7% per year. For 30 to 39-year-olds, the incidence increased by 1.2% per year. And among 40 to 49-year-olds, rates were stable during the early period of 2006 to 16 and then increased by 1.7% per year. These results indicate that while the absolute burden remains highest in ages 40 to 49, increases are also occurring across the entire age range, including the youngest groups where breast cancer is less common. By race ethnicity, Asian and Pacific Islanders had increases noted, but they weren't statistically significant. In contrast, Hispanic individuals experienced a 1.1% increase per year over the study period. Non-Hispanic Black individuals had stable rates from 2006 to 16, followed by a decrease of 3.1% per year from 16 to 21. And non-Hispanic whites experienced an increase of 0.7% per year in incidence over the study period. This figure shows a changing stage distribution over time with increases in early stage diagnosis alongside continued increases in metastatic or stage 4 incidence. A notable shift occurred after 2016. For stage 1 cancer, there were stable rates from 2006 to 16, followed by an increase of 13.9% per year from 2016 to 2021. Stage 2, there were stable rates from 2006 to 16, followed by a decrease of 18.6% per year. For stage 3, there were stable rates also from 2006 to 16, followed by a decrease of 9.1% per year from 2016 to 2021. And stage 4 incidence saw a 2.4% increase per year over the study period. This slide shows female breast cancer's 5-year relative survival rate. Relative survival shows whether disease shortens life, and it's calculated by dividing the percent of patients with the disease who are still alive at the end of a time period by the percent of people in the general population of the same sex and age who are alive at the end of the same time period. You can see that there's two colors on this slide. The darker color is the most recent 5-year time period of 2014 to 2021, and the lighter time period is 2006 to 2013 for comparison. So you can see how relative survival may have changed over time. Survival was relatively stable between the two time periods for early onset breast cancer. By race ethnicity, in 2014 to 2021, relative survival was highest among Asian and Pacific Islanders at 92.7%, followed by non-Hispanic whites, Hispanic, and non-Hispanic Black patients at 81.5%. Our finding of the lowest relative survival among non-Hispanic Black females compared to other racial ethnic groups is consistent with prior findings, which attribute the disparity to later stage at diagnosis, more aggressive tumor types, and barriers to accessing healthcare. By age, the highest survival was in the oldest young adults of ages 40 to 49 compared to 30 to 39 and 20 to 29 years at diagnosis. And of course, stage 1 had the highest relative survival and at 98.8%, and stage 4 had the lowest at 43.9%. Importantly, stage 4 survival did significantly improve between the two time periods from 38.6% in 2006 to 2013 to 43.9% in 2014 to 2021. Next is early onset thyroid cancer. The incidence of this increased by 6% per year from 2006 to 2012, but then stabilized from 2012 to 2021. The highest incidence of early onset thyroid cancer was among ages 40 to 49, Asian and Pacific Islanders, those diagnosed at stage 1, and females. Risk factor for early onset thyroid cancer include history of irregular menstrual cycle, Hashimoto thyroiditis, history of goiter and exposure to radiation, and obesity. This plot summarizes thyroid cancer incidence trends by age. Across age group, there were increases that were concentrated in the earlier years of diagnosis from 2006 to 2015 for 20 to 29-year-olds, and 2006 to 2012 for the older age groups. 20 to 29-year-olds saw a 3% per year increase in 2006 to 2015, followed by stable rates. And 30 to 39-year-olds experienced a 6.6% increase from 2006 to 2012, followed by stable rates. And finally, 40 to 49-year-olds experienced a 5.8% increase per year, followed by stable rates. By race ethnicity, Asian and Pacific Islanders experienced a 5.4% increase per year from 2006 to 2012, followed by stable rates, whereas Hispanic individuals experienced a 5.4% increase in incidence per year from 2006 to 14, followed by stable rates. The non-Hispanic Black population experienced an increase of 12.1% per year from 2006 to 2011, followed by a decrease of 3% per year. And non-Hispanic whites experienced a 5.8% per year increase from 2006 to 12, followed by a 2% decrease per year from 2012 to 2021. Stage 1 incidence increased by 8% per year from 2006 to 2010, and the later increase was not statistically significant. Due to the rarity of thyroid cancers among young adults diagnosed at stages 2 through 4, we were unable to analyze their trends during the study period. However, other findings observing increasing incidence of larger thyroid tumors among young adults less than 30 years have been cited in the literature. Our findings of increased incidence during the beginning of the study period coincides with a period of increased imaging and incidental detection of small thyroid tumors during the early 2000s. Incidence of early onset thyroid cancer was higher in females than in males. By sex, both females and males experienced early increases of 5.9% per year in females and 5.6% per year in males during 2006 to 2012, followed by stable incidence during 2012 to 2021. 5-year relative survival is high for early onset thyroid cancer in California. Females have slightly higher survival than males, though the estimates were similar across time periods. By race ethnicity, non-Hispanic white individuals had the highest 5-year relative survival rate at 99.7%, followed by Asian and Pacific Islanders, Hispanic, and non-Hispanic Black at 98.1%. By age, the 5-year relative survival was over 99% for all age groups, and by stage at diagnosis, relative survival was highest at stage 1 and lowest at stage 4. Although the relative survival for stage 4 increased, it wasn't statistically significant. Next is early onset colorectal cancer. The incidence increased by 2% per year overall from 2006 to 2021. The highest incidence in 2021 was among the oldest age group of 40 to 49-year-olds, non-Hispanic Black individuals, those diagnosed at stage 3, and males. Risk factors include obesity, sedentary lifestyle, diets high in processed and red meats, and low in whole grains, fruits, and vegetables. By age, incidence was highest in 40 to 49-year-olds compared to younger age groups. Rates were stable in 20 to 29-year-olds and increased by 2.8% per year for 30 to 39-year-olds. Among 40 to 49-year-olds, rates were stable from 2006 to 2013 and then increased by 3.3% per year from 2013 to 2021. By race ethnicity, changes in incidence were not statistically significant for Asian and Pacific Islanders. For Hispanic individuals, there was an increase of 3.3% per year on average over the study period. Non-Hispanic Black population experienced stable rates, or at least the changes were not statistically significant, and non-Hispanic whites experienced a 2.1% per year increase in incidence. For stage 1 colorectal cancer, there was a 1.5% per year increase in incidence. Stage 2 incidence was stable, and stages 3 and 4 also increased over the study period by 2.1% and 3.1% respectively. Incidence was highest in 2021 at stage 3. Female incidence increased by 2.1% per year overall, and among males, rates were stable from 2006 to 2012, followed by a 2.9% increase from 2012 to 2021. Across both time periods, females consistently had higher 5-year relative survival than males, and estimates were similar between time periods. Survival was highest among the oldest age group in both periods, at 40 to 49-year-olds. Racial ethnic differences persisted for colorectal cancer young adult patients. The highest survival in 2014 to 2021 was among non-Hispanic white, then Asian and Pacific Islander, Hispanic, and then lastly, non-Hispanic Black patients. Both stage 3 and stage 4 survival improved from the first to the second time period. Stage 3 improved from 75.8% to 80.1%, and stage 4 improved from 17.8% to 21.3%. Similar findings in previous studies attributed this trend to advances in surgical methods and treatment of metastases to the liver. However, disparities in relative survival were observed by race ethnicity, with the lowest rate among non-Hispanic Black and Hispanic individuals, suggesting that not all subgroups are benefiting equally from these treatment advances. Overall, the lowest survival in 2014 to 2021 was among ages 20 to 29, non-Hispanic Black patients, Hispanic patients, stage 4, and males. Early onset testicular cancer is next. The overall incidence increased by 1.3% per year over the study period. The highest incidence was among ages 30 to 39 at diagnosis, Hispanic individuals, and those diagnosed at stage 1. Risk factors for testicular cancer are not well understood, although cryptorchidism, low birth weight, and cannabis use have been associated. In 2021, incidence of early onset testicular cancer was highest among males ages 30 to 39, and the lowest was among ages 40 to 49. This is consistent with the average age of 33 for testicular cancer diagnosis in the United States. Among the youngest age group, incidence increased by 1.7% per year from 2006 to 2018, followed by stable rates. Among 30 to 39-year-olds, incidence increased by 2% per year over the study period, and rates were stable for 40 to 49-year-olds. In 2021, the highest incidence was among Hispanic males, followed by non-Hispanic white, Hispanic, and lowest among Asian and Pacific Islanders. Among Asian and Pacific Islanders, rates increased by 2.6% per year. Rates increased by 3.3% per year among Hispanic individuals and were stable among non-Hispanic white individuals. Non-Hispanic Black rates were suppressed due to low numbers. According to the American Joint Committee on Cancer, or AJCC, testicular cancer can be staged 0 to 3, where stage 3 indicates distant cancer metastasis. The highest incidence was in stage 1, and the lowest was stage 2. Over the study period, incidence increased for males diagnosed at stage 1 by 1% per year, and rates were stable among those diagnosed at stages 2 and 3. Survival estimates were similar between the two time periods, and survival was generally high, but disparities remained. From 2014 to 2021, non-Hispanic whites had the highest 5-year relative survival, followed by Hispanic individuals, Asian and Pacific Islanders, and non-Hispanic Black patients at 86.7%. In both studies, males ages 30 to 39 years had the highest 5-year relative survival, followed by those aged 40 to 49 and 20 to 29 years. And of course, stage at diagnosis heavily influenced 5-year relative survival, with stage at diagnosis 1 having the highest relative survival and stage 3 the lowest. And finally, our last site was early onset uterine cancer. The overall incidence of which increased by 3% per year from 2006 to 2021. The highest incidence in 2021 was among ages 40 to 49, Hispanics, and those diagnosed at stage 1. Risk factors for early onset cancers include obesity, sedentary lifestyle, and type 2 diabetes. Up to 60% of uterine cancers may be attributed to obesity, the prevalence of which is highest in Hispanic individuals in the United States. By race or by age, rates were stable from 2006 to 18 for 20 to 29-year-olds, followed by an increase of 18.8% in 2018 to 2021. Among 30 to 39-year-olds, there was also an increase, from 2006 to 18 of 5.3% per year, followed by rates that were statistically not significantly changing. For 40 to 49-year-olds, there was an overall increase of 2.6% per year. By race ethnicity, the highest incidence in 2021 was among Hispanic individuals, followed by Asian and Pacific Islanders, non-Hispanic white, and non-Hispanic Black, and Asian and Pacific Islanders. Non-Hispanic Black. Asian and Pacific Islander rates increased by 2.8% per year. Hispanic rates increased by 4.3% per year. Among non-Hispanic Blacks, incidence increased by 4.8% per year from 2006 to 17, and then were stable from 2017 to 2021, and rates were stable among non-Hispanic whites over the study period. Stage 1 early onset uterine cancer increased by 3.9% per year, and stage 4 also increased by 6.8% per year. Rates were stable for stage 2 during the study period, and among those diagnosed at stage 3, rates increased by 8.7% per year from 2006 to 2020 or to 2010, and then were stable from 2010 to 2021. Relative survival was stable between the two time periods across race, age, and sex. Survival was highest in non-Hispanic white females at 90%, followed by 88.3% in Asian and Pacific Islanders, 87.1% in Hispanic females, and 78% in non-Hispanic Black patients. Consistent with other studies, we found the lowest relative survival after uterine cancer diagnosis among non-Hispanic Black patients. Some studies of older adults in the United States have found that Black females have a mortality rate of 80% higher than non-Hispanic white females for endometrial cancer, which is the most common type of uterine cancer, due to more aggressive tumor types, higher stage at diagnosis, worse access to treatment, and the use of less aggressive treatments. By age, survival was highest in females aged 30 to 39, followed by 40 to 49, and then 20 to 29. Survival at stage 1 was highest and lowest at stage 4. Next, I'll briefly touch on early onset cancer survivorship. Cancer is associated with significant morbidity. With longer survival times following cancer diagnosis, young adults face several adverse health outcomes, such as the development of chemotherapy-induced peripheral neuropathy, which can cause pain, numbness, and the loss of sensation in a patient's hands and feet. Chemotherapy may also result in the later development of cancers such as myelodysplastic syndromes, leukemia, lymphoma, or late effects such as cardiovascular disease, which impact survival. Additionally, fertility preservation is a concern for many young adults with cancer. Treatment may limit endocrine function or cause infertility among survivors. As Benjamin Franklin stated, an ounce of prevention is worth a pound of cure. Some ways to prevent early onset cancers include the HPV vaccine for individuals under 27 years of age, adherence to cancer screening guidelines and following up after abnormal results, quitting or not using tobacco, exercising regularly and maintaining a healthy weight, consuming a healthy diet high in fiber and low in red meat, limiting alcohol consumption, and limiting exposure to carcinogenic compounds such as tobacco, smoke, and pesticides. However, some risk factors for early onset cancers are non-modifiable, such as genetic predisposition. Our study had limitations. Because of the rarity of cancer in some subgroups, trends and incidence could not be calculated. We were also unable to examine incidence or relative survival by known cancer risk factors such as carcinogenic exposure, obesity, tobacco and alcohol use, and genetic predisposition. Despite these limitations, our report demonstrates the need for improved early onset cancer prevention and screening, especially among disadvantaged subgroups of young adults in California. In summary, early onset cancer increased in California from 2006 to 2021 with disparities in incidence and relative survival by age at diagnosis, race, ethnicity, and sex. Nearly 80% of early onset cancers were among females, driven by female breast and thyroid cancers. The top incidence sites in the latest 5-year period were among breast, thyroid, testicular, uterine, and colorectal cancers. The greatest increase in incidence was in uterine cancer, followed by thyroid, colorectal, testicular, and female breast cancers. For all 5 cancer sites, the incidence among Hispanic individuals and those diagnosed at stage 1 disease increased. And the lowest 5-year relative survival was experienced by racial ethnic minorities, those diagnosed at later stages, and males. Few improvements in relative survival were observed over the study period. But despite few survival improvements overall, notable gains did occur for breast stage 4 and colorectal stages 3 and 4. Here I provided the link for the full report, and I welcome you to contact me if you have any questions after the webinar. And I just wanted to thank you again for your attention and for inviting me to speak at this webinar, and I welcome any questions.
Thank you so much, Julianne, for your informative presentation on the incidence and survival of early onset cancers in the state. So at this time, I'd like to open the floor for any questions or comments. And I see a question on the chat from Arlene. Incidence of breast and uterine cancer diagnosis increased, notably in Asian Pacific Islander population. Has there been a study on specific variables that attributed to this unique to this population?
That was outside of the scope of our study. Unfortunately, we weren't really able to look into risk factors and incidence by risk factors. However, studies have shown that um, changing diets in Asian and Pacific Islanders have contributed to increasing incidence, and also a lower BMI among Asian and Pacific Islanders is associated with increased cancer risk than the same BMI in other racial ethnic groups. Also in thyroid cancer, I have read that and of course, Asian and Pacific Islanders are a very heterogeneous group, but diets high in nori or seaweed and seafood can also be very high in iodine, which can increase thyroid cancer incidence. So it's definitely a really great question, and it's definitely worth looking into all the literature out there, which I agree, it's a very interesting point. And I wish that we were able to separate out our incidence rates by Asian and Pacific Islander subgroups.
Thank you, Julian. And then we have some other questions that we received via registration. Are you seeing
Okay.
differences in early onset trends between urban and rural areas?
Unfortunately, we weren't able to look at urban and rural trends for this report. It was kind of beyond the scope of our report. But I know that's of very high interest right now. And I did see in the literature that it kind of changes by cancer site. Colorectal cancer, there's a higher burden in rural areas, but there's on average later stage of diagnosis and worse survival in rural areas as well. But breast, thyroid, and testicular cancer also all have higher burdens in urban areas, actually, which may be related to increased imaging and access to imaging in urban areas, because there's actually worse survival for those same cancers in rural areas for the young adult population.
Thank you, Julian. And I saw somebody went off mute. Sherilyn, do you have a question?
Oh, sorry, I didn't mean to go off mute.
No worries. Does anybody else have question on the chat? We do have another question. How do you decide when to suppress annual counts under 20, and what challenges does that create when analyzing disparities?
So we chose to suppress counts under 20 to follow the National Cancer Institute CCR program, because states or rates can be unreliable and statistically unstable, and very sensitive to random variation when they're based on low counts. For example, if there's a rate based on only 5 counts, if there's one additional count the next year, that changes the rate by 20%. So we chose to follow NCI-CCR's rule on that. It also protects confidentiality for stratified analysis, but it does present challenges when we have to suppress data, of course, like not able to separate out the Asian and Pacific Islander subgroups, and also we weren't able to present rates on Native Americans in this report due to low counts.
Thank you, Julian. And then from the limitations that you listed on the survivorship prevention and limitations, which one do you think would change the findings most if improved?
If we had rates by risk factors, I think it would definitely help us to effectively identify the best interventions especially to reduce disparities in incidence and late stage diagnosis. So I don't know that it would change the results, but it would be great to just have more granular results in terms of being able to include risk factors or look at smaller subgroups.
And then the question on colorectal cancer, since colorectal screening starts at 45 now, do you anticipate this guideline shift impacting future early onset trends?
Hopefully it will detect and be able to therefore remove precancerous polyps and lesions in young adults. And so hopefully that would reduce incidence and reduce late stage diagnosis as well. But of course, it depends on uptake. And as I noted in one of the slides, the uptake for colorectal cancer screening has been found by one study to be less than 20% for for individuals ages 45 to 49. So hopefully, although it depends on uptake.
Thanks, Julianne. Trying to check the chat. I don't see any other question. We received a comment that it's a very informative presentation. And yes, we will share the slide deck and recording to all the registrants after the webinar. So I guess looks like we don't have any more questions at this time. So we'll go ahead and wrap up early and advance to the last slide. Thank you again, Julianne, for sharing such valuable insights with us today. Please take a moment to complete the short webinar evaluation that my colleague Joyce had shared in the chat. Our next webinar is on June 17th, where we will hear a presenter of California Behavioral Risk Factor Surveillance Systems, or BRFIS. Again, the recording and slide deck will be shared with you via email. Thank you all so much for joining us today, and see you at the next webinar. Thanks, everyone.